diseases, we can think of a cause, and the cause can be a microorganism. But you have discussed that for lung cancer, it is difficult to name a cause. We know that cigarette can increase the risk of lung cancer. We know that air pollution may be responsible for increasing the chance of getting the lung cancer. But it is very difficult for us to talk about cause of lung cancer. And we also had another example, the cardiovascular disease. And can I ask you, what is the cause of cardiovascular disease?
Hypertension.
High blood pressure is not the just cause. It is one of these factors. Okay? We know that cardiovascular diseases have many risk factors. One of them is high blood pressure. Yes, you're completely right. The another one may be obesity and low physical activity that can produce obesity, and after obesity can produce cardiovascular diseases. Smoking, high blood pressure, yes. Again, okay.
High cholesterol.
High cholesterol,
Poor diet.
poor diet, high stress, some genetic predisposition. Predisposition means that some family, history of cardiovascular disease are risk factors of having or getting cardiovascular disease. Also for skin cancer, what is the cause of skin cancer? Sunlight is one of, direct sunlight is one of the causes of skin cancer. We know that some kinds of skin cancer may be due to
Exposure to certain chemicals.
exposure to certain
Genetically.
chemicals, genetic, UV radiation, and some cases are unknown. We have some cases of skin cancer without any known risk factors. Some cases of skin cancer may occur without any genetic susceptibility, without any family history, without any exposure to sunlight, for example, in some areas of the body that are not exposed to sun. So we can talk of two models. The first model is a triangle. The triangle model, this model has three components. The first component is an agent. There should be a suitable media to transfer, to spread this agent to a host. And the host should be susceptible. Susceptible means that he or she should not be immunized. Okay, some people are immunized. The immunization may occur due to vaccination. Some people may be immunized due to getting the disease in the past, and some people may have innate immunity. Some people may have immunity without any exposure, without any vaccination or getting the disease. So for infectious diseases, this triangle model may be good. Because for any infectious disease, we have an agent. And without agent, the disease cannot occur. If we exclude Shigella, the shigellosis will not occur at all.
Yes.
If you exclude streptococcus, streptococcal, sore throat cannot occur. So for infectious diseases, we can talk of an agent. And that agent is responsible for producing disease. But at the same time, we know that many people may receive the agent but did not get the disease. What is the cause? Why some people?
Not the right environment.
Yes?
Not the right environment, right?
Environmental factors, you know? What is the another reasons?
Height.
Immunity. And in some cases, we still don't know why some people may get the infection, some people may be infected, but the disease will not occur at all. What is the agent for cardiovascular disease? We just talked that for cardiovascular disease, it is difficult to talk of an agent. So for infectious diseases, the triangle model may work good. May work well.
When we talk about health, we talk about different.
Thank you very much. When we are talking about non-communicable or non-infectious diseases, the triangle model is not good, is not suitable. We prefer to use the whale model. In the whale model, we have a human host at the center and the environment that surrounds the human host. And we divide the environment into three components. The first component is biological environment. What do we mean by biological? What is the biological environment?
Our bodies.
Thank you. Microbes, viruses, parasites, fungi, any living organism is classified as biological environment. So for infectious diseases, the biological environment is more important than the other two components. The second component is physical and chemical environment. Dr. Zaha, how can I slideshow? Food size. Here. The physical and chemical. In this slide, you can just see physical environment, but by physical we mean physical and chemical environment. What is physical and chemical environment? Air pollution, water pollution. These are chemical, risk factors. Can I ask you to mention some physical risk factors?
Physical behavior on our own.
No, not physical activity.
That's social.
Yes.
I don't understand
Find some physical agents. What are some examples of physical agents that can increase the risk of getting disease? It's very simple. You have mentioned. Yes, please. Sorry? Air pollution. Air pollution can, some kinds of air pollutants may be chemical, for example, sulfur dioxide is a chemical agent. But the particles are the climate. Thank you very much. Climate is a physical and some more tangible physical environment. Sunlight. You just mentioned that sunlight is a risk factor for skin cancer. Is it chemical, biological, or physical?
Physical.
You know that UV radiation is a physical agent. What about heat? Heat is stress. Or cold weather. The weather. Weather is also physical. Stress. No, stress is not physical. Stress is classified as social environment. So some risk factors may be social. Please give me some more examples about social risk factors. Human behavior, human interaction, the human, environment. When we have interaction with each other, we can produce some social environment for each other.
And also the
Lifestyle, thank you.
the cultural practice of
The culture, practice of the community. The culture is also a social environment. Some cultures may predispose getting some special kinds of diseases. Excuse me. Yes, please. Exercise. Exercise is, classified as lifestyle, and lifestyle is also classified as social environment. So we prefer to use this wheel model because this wheel model can explain the relation between causes, between risk factors and diseases much better than triangle model. In triangle model, we have concentrated on just an agent. We just talked about an agent. But in non-communicable disease, in non-infectious disease, we know that there are many risk factors. So talking about an agent alone is not sufficient. So this would be much better than triangle model. This is a host, a human host, surrounded by three kinds of environment. And what is at the center of human host?
Genetic code.
Genetic codes. We know that many diseases are results of interaction between genetic codes and environmental factors. Okay?
Yes.
So the genetic message or genetic code, these codes are inside our body, and we are surrounded by an environment that is outside our body. And the interaction between genetic codes and different environmental factors can affect our health. Our health is affected by interaction between biological environment, microbes, viruses, fungi, prions. You know what is prion or prion? Have you ever heard of Creutzfeldt-Jakob disease? In virology, there are some new branches of organisms. Something less than viruses are called prions. All of these agents can be classified as biological environment. These, environmental factors can have interaction with social environment, with physical and chemical environment, and their interaction with genetic codes. We know that many people have some traits, some genes, but they will not get the disease. For example, two identical twins have exactly the same genetic material, but one of them may get some non-infectious disease and another will not get the disease. This is due to interaction between these genes and the environment. Some genes may not be able to show their properties in the human. Okay, now that you are familiar with risk factors and preventive factors, what did we call the whole risk factors and preventive factors yesterday? Thank you. Health-related states. Or events. Thank you. Actually, exactly the case. When we are familiar with health-related states and events, we know that for prevention, we should reduce exposure to risk factors, and we should increase exposure to preventive factors. We have some risk factors. For example, you have mentioned that obesity is a risk factor. What is a protective factor for cardiovascular disease?
Exercise or the lifestyle.
Exercise, healthy lifestyle. What else? Good diet is again a kind of health lifestyle with low fat, with high fruits and high vegetables. Is another protective factor.
Actually, everything opposite to the risk factor.
Everything opposite to risk factor is protective factor. So, high blood pressure is a risk factor. Normal blood pressure or lower blood pressure is a protective factor. Low physical activity is risk factor, and high physical activity is protective factor. If we exclude the risk factor, we can talk about protective factors. There is a generic question. Which one is better? Prevention or treatment of diseases?
Prevention.
Everybody can say that prevention is much better. But there is a problem. The problem is that, let's go back to yesterday. You know that hypertension is a disease or a risk factor?
Both of them.
Both of them. If we assume that hypertension is a disease, how can to prevent hypertension?
A good diet.
Improve the quality of diet,
Lifestyle.
physical activity, means lifestyle and any other, So lifestyle is broader than just physical activity. But, so these factors and many factors can produce or can increase the chance of high blood pressure or hypertension. And we know that hypertension may be a risk factor for cerebrovascular accident. Cerebrovascular accident or events on brain. How can prevent cerebrovascular accident? By decreasing blood pressure. So, if we treat patients who have hypertension, we can prevent cerebrovascular accident. We know that hypercholesterolemia may be a risk factor for hypertension or for cardiovascular disease. So, if we want to decrease the rate of cardiovascular disease, we can treat patients with hypercholesterolemia. So we know that treatment is also a kind of prevention. Although we know that prevention is much better than treatment, but in a broader term, in a holistic approach, in a holistic view, we know that treatment of a disease that is a risk factor for another disease can prevent the second disease. The first disease can be a risk factor for second disease. CVA also is a risk factor for death. So, by treating cardiovascular accident, cerebrovascular accident, we can prevent them. So, when we are talking of prevention, we are talking of any intervention. Any intervention is public health is classified as preventive measures. And I'm sure that you know that we have 3 levels of prevention. Primary,
and tertiary.
secondary, and tertiary. What is the primary prevention? Vaccination.
Before infections.
Very good. You gave an example of an infectious disease. By vaccination and prevention of infection, we can prevent some infectious diseases. Can I ask you to give me an example of non-infectious disease prevention? Primary prevention for non-infectious.
Exercising and non-smoking.
Exercising and quitting smoking for prevention of lung disease or heart diseases. So, in primary prevention, we prevent the development of the disease by excluding risk factors. Okay, we remove bacteria from water by purification of water. When water is free of bacteria, the chance of diarrhea will be decreased. we cannot eliminate diarrhea, just we are decreasing the rate of, or the chance of, or the risk of getting diarrhea. In primary prevention, we remove the risk factors and prevent the development of disease. What do we do for secondary prevention?
Treating the disease that we have.
Attacking the disease.
Treating the disease to do not have other disease because of the first disease.
Thank you very much. And you just wanted to say that?
Detect the disease in the early stage.
Thank you very much. If we detect disease in early stage, it can be classified as a secondary prevention. But if we treat the disease at a later stage, it cannot be classified as primary secondary prevention. It is tertiary. Okay. So the treatment is a prevention, but the stage of disease is very important. If the disease is asymptomatic means that the patient does not have any signs. The patient is not aware of having disease. The people think that they are healthy. So, how can we prevent the diseases? How can we detect earlier stage of diseases in people without any signs and symptoms? We know that people without signs, people without any symptoms do not refer to clinics.
Primary school examination and annual measurements, blood pressure.
Thank you very much. Yes, you please.
Regular checkups.
Regular checkups. Thank you very much. Our answers are correct. In secondary prevention, usually we go to the people. When signs and symptoms are present, people go to the physician. But when there is no signs and symptoms, physicians should go to the people. So for secondary prevention, we usually go to the people, we usually go to the society and examine people. For example, we can go door to door, home to home, and ask people, please come here, I want to measure your blood pressure. I want to know whether you have early stage of hypertension or not. So in secondary prevention, we should, be active. But in tertiary prevention, we usually are rather passive. Passive means that I stay in clinic and patients come to me. But in secondary prevention, the people do not have any signs and symptoms, so they do not come to my office. I, as Minister of Health, as you know, as a healthcare provider, should go to the community and should seek for any early signs and symptoms of disease, and then try to treat these patients to prevention and progression of the disease. This is very important to both detect the diseases and also to treat them. Just for example, let's think of a breast cancer case. What is the first event in producing breast cancer? The first event.
Regular checkup.
No, the first event that produces lung cancer.
Abnormal growth for cell.
Abnormal growth of a cell, or a mutation. A mutation. A mutated cell is the first event. So, this is a normal woman. This is dead, unfortunately. This may be a mutation of a single cell. does this mutation have any signs or symptoms?
No.
No. Can we detect this mutation? No. Because for detection, this cell should multiply, should produce a mass, and this mass should be large enough to be detectable by, for example, physical examination or by mammography or by ultrasonography. This is the presence of signs and symptoms. This means that at this stage, patients or the woman may notice something in his breast. She noticed that there is a lump. She may experience pain. She may experience bleeding from her breast. Okay? So, if we detect in this stage and treat the patient, the treatment may be surgery, maybe radiotherapy, maybe chemotherapy, and everything else. If we diagnose the patient after signs and symptoms, it is classified as tertiary prevention. But by this kind of prevention, we try to return the woman to normal life. We try to reduce the inabilities. We try to reduce the pain of the patient. We try to increase the quality of life of that people. But there is another stage. In this stage, there is no signs and symptoms. So people usually do not refer to physicians. But we can detect the tumor without any signs, without any symptoms, by some measures. What are these measures?
CT scan?
CT scan, mammography, ultrasonography, physical examination by an expert physician. The woman herself cannot detect a tumor because it is very difficult for her to differentiate between normal, milk lobules from the tumor, or from the abnormal tumor. But an expert physician can detect very small, masses. And sometimes with some biochemical markers. Some tumoral cells can produce a chemical agent that is called biological marker or biomarker. A chemical that is not normal. Normal cells cannot produce this biochemical agent. If we detect patient in this stage, but the treatment is not different from the treatment of this. For example, if we offer the people surgery, chemotherapy, and radiotherapy, and if we offer the same treatment to this type of patients, this is not called a good secondary prevention. For secondary prevention, we should detect people in earlier stage, and we should offer them a curative treatment. We should offer them a treatment that extends their life expectancy. Just for example, suppose that the first mutation occurs in year 2000. In 2010, we can detect this cancer at earlier stage. 5 years later, signs and symptoms appear. And 5 years later, even with treatment, the patient dies. So the life expectancy from diagnosis is 5 years. Life expectancy means that how many years we expect that on average these people live.
Evaluate the mental capacity, okay? So if I ask a CT error and the
I think
total
there is.
test for that CT, then you say how much is there? Margin 5% is there, how much is the impact for that, how much is lateral for the delay, how much is the trigger?
This lesson is very essential for me from the beginning because they have many problems. If if the physician offers a treatment, but without any change in the final situation of the patient, the final situation of that woman, this is not a good secondary prevention. In which situation can we say that we offered a secondary prevention? If the treatment in this location extends the life expectancy by, for example, 5 years, we can say that the secondary prevention was successful. Or, in another terms, the treatment in this late stage may be surgery plus chemotherapy and plus, for example, radiotherapy. But in earlier stage, by just surgery, the disease can be disappeared. So, in some cases, the treatment may be less painful. We may offer much simpler treatments to the patients. We may eradicate the disease. We may increase the life expectancy after diagnosis. So as a summary, for which diseases secondary prevention is possible is mentioned. First, we should be able to diagnose disease in early stage. It means that we should have access to measures that are valid, the measures that are sensitive, the measures that are specific for detection of disease. We will talk about sensitivity and specificity in later sessions. But now, just we say that for secondary prevention, we should have access to an early diagnosis tests. The first criteria is a good test. What is the second criteria?
Curable treatment. A curable treatment.
Yes, existence of a curable treatment. Existence of a treatment that is different from the ordinary treatment. Existence of a treatment that can change the ultimate situation of the patient. Existence of a treatment that can extend the life expectancy. Yes.
So is this considered as a second or tertiary?
Secondary prevention. Because
Treatment.
the treatment is secondary because we diagnose the patient in early stage without appearance of signs and symptoms. Okay? We are just talking about patients without any signs and symptoms. Diseases that the people are not aware of having them. Okay? For secondary prevention, for having a successful secondary prevention, at first we should have a good test to detect the disease at an earlier stage. Second, we should have access to effective therapeutic measures that can change the prognosis of the patient. Changing the prognosis means that we can extend the life expectancy, we can reduce the painfulness, we can increase the quality of life. And the third criterion is that the test should be simple, should not be expensive, should be acceptable. Acceptable means that the test should not be painful. If I say that I can diagnose breast cancer by yearly sampling of the breast, it's not acceptable for women because it is invasive, because it is painful. If you say that I can detect your cancer in earlier stage by means of ultrasonography or by means of CT scan, which one is better? ultrasonography or CT scan. In terms of invasiveness, ultrasonography is not invasive, but CT scan uses radiation, and radiation may have some risks. So the test should be safe, and the test should be cheap. How many women we have in Iraq? What is the population of women in Iraq?
22 million.
22 million. How many of them are older than, for example, 40 years?
Can we say 5 million?
At least 5 million. If we want to offer mammography for 5 million women in a year, we should prepare a huge amount of money because mammography is expensive. But if we can detect it by just physical examination, this option may be much better because physical examination is not as expensive as mammography. Another problem with mammography is that mammography needs some equipment, and these equipments may not be available in any cities or any village of the country. But you can send some physicians, provide some, medical examination, physical examinations by providing trained physicians in the country. So the test should be cheap, should be simple, should be safe, should be available, should not acceptable, should not need any expensive and sophisticated technology. Some tests, evaluations may need equipment that are just located in big cities. If we have all these criteria, we can say that we are talking of a secondary prevention, a good secondary prevention. You have mentioned about the primary school examinations. Which disease or which diseases are we, trying to detect in primary school examination? Vision problems, myopia. What technology we need for vision impairment detection? Just not an optimeter, just a trained personnel without any, university degree can detect, because we have a Snellen chart. Snellen chart is a chart that we put in 6-meter distance from people and ask them to say the direction of the, for example, the letters. So optometric evaluation may be more complete than this just Snellen chart. Because in optometric examination, usually some technician with at least bachelor degree should use some equipment to watch the, the eye, and the full examination may be needed. But for screening, one simple test may be enough. Using a Snellen chart with the people without any specified education. A university degree is not needed. Just a high school level of education is enough for using a Snellen chart. So it is a very good example of secondary prevention. The children are not aware of the problem because we have 2 eyes, and if we do not separate the left eye from right eye, we cannot detect eye problems. When the optometric examination, the Snellen chart examination differentiates, asks the people to cover the one eye and then try to detect the direction of letter, and then the other eye by detecting this problem at early stage and referring these people to the optometrist. And the optometrist can then do further examinations. By screening, we cannot detect diseases exactly. We just can select people who may have the disease. And after this screening, we should do some more sophisticated tests, but not for the whole students. In primary school, we may have 400 students. We just select 20 of them and refer them to ophthalmologists. So the ophthalmologist, instead of examining 400 students with sophisticated equipment, can concentrate on just 20 of them that may have the problem. So in screening or in secondary prevention, we select people who may have the disease and we refer them for more sophisticated examinations to confirm the disease. If it has been confirmed that the people have the disease, we can then refer them for treatment. Even by mammography or by physical examination, we cannot say that 100% we are certain that this woman has breast cancer. We can say that there is a suspicious tumor. There is a suspicious mass. And then we can refer them to a gynecologist or to a surgeon, and this surgeon can do some more sophisticated tests. In this stage, we can offer them biopsy. We cannot offer biopsy to whole population. But some people who have a mass may accept this invasive measure of detection because we know that the chance of having cancer in this group of patients is higher than the total population. So the critical difference between secondary and tertiary prevention is the presence or absence of signs and symptoms. If the signs and symptoms are appeared and we offer treatment, we are conducting tertiary prevention. If we offer treatment to people without any signs and symptoms, in people who are not aware of having disease, but we detected their disease in early stage and offered them the treatment, we are doing secondary prevention. So, what is prevention of death caused by heart attack? Is it primary prevention, secondary or tertiary prevention?
Tertiary.
After heart attack, prevention of death is tertiary prevention because we have to reduce the complication of heart attack. This is a tertiary prevention. Prevention of heart attack caused by hypertension.
Secondary.
If we detect hypertension in people who are not aware of their problem, it can be a secondary prevention. If we do regular examinations and find that some people have some early stage of blood pressure without any signs, without any symptoms, it can be classified as secondary prevention. But if the patient have an established hypertension disorder, established means that a hypertension disorder, a hypertensive disease, a hypertensive patient with signs of hypertension. For example, he may have complaint of headache, he may have complaint of nose bleeding, we may have some complication of kidney disorders, and we measure the blood pressure and we notice that she or he has blood pressure. This is called tertiary prevention. But if we detect the high blood pressure in routine examination as an accidental finding without any sign and symptom, this can be classified as secondary prevention because the patient were not aware of the disease. Prevention of hypertension caused by obesity. Primary prevention, because obesity is a risk factor for prevention. And by removing the risk factor, we can prevent development of hypertension. In primary prevention, we prevent the disease, development of disease. But in secondary prevention, the disease has already been developed, but is in its earliest stage. It's the distinction between primary and secondary is that in primary, we prevent the development of disease, but in secondary prevention, the disease has already been developed. We are just trying to detect it in its earliest stage and offer the patient, offer the people some effective treatment. Prevention of obesity caused by inactivity.
Also primary.
Also primary. Prevention of inactivity caused by sedentary lifestyle. What is sedentary lifestyle? Your lifestyle. Addiction to mobiles, addiction to tablets, addiction to car, addiction to using car. We are all some addictions to internet, to our cell phones, to our, any other facilities that are available for us. So if we change the lifestyle, we can increase physical activity. It is again a very early stage of primary prevention. In some books, you can see that there are more than 3 levels of prevention. There is also primordial prevention. Primordial prevention means the changing of the culture that risk factors does not appear. By healthy lifestyle, we can provide an environment that people even do not think of inactivity. But as a classical definition or classical classification, we can just classify our intervention as 3 levels. So all interventions in medical and public health are prevention. Some of them are primary prevention, and when the ordinary people talk of prevention, they are just talking of primary prevention. But in medicine, we know that treatment is also prevention. Without any signs and symptoms, it usually be secondary prevention. After presence of signs and symptoms, it could be a tertiary prevention. So in this table, we can see a brief explanation or simple explanation. Primary prevention is the preventive of initial development of the disease by immunization, by reducing exposure to some risk factors. In secondary prevention, by early detection of existing disease, the distinction is the development and the existence of disease. In secondary prevention, the disease has already been existed, but in earlier stage to reduce severity and complication, for example, screening for cancer, screening for amblyopia, screening for hypothyroidism in newborn babies, and tertiary prevention, reducing the impact of the disease by trying to return the patient to normal life, such as rehabilitation for stroke. We can skip these slides. So another examples. We know that fluoridation of water is primary, exercise, quit smoking, annual measurement of blood pressure. Annual measurement of blood pressure is usually secondary. But if we offer this examination to patients who have high blood pressure, this can be tertiary also. So if the people do not have any signs and symptoms, you are right, this is secondary prevention. But if we ask the patient, we know that they have severe hypertension, and we ask them, please measure your blood pressure regularly each day, and if the blood pressure is high, please return to me. It can be classified as tertiary because the hypertension has established, we have diagnosed, the patient is aware of his or her situation, and we try to reduce the impact. But if I just talk about annual measurement of blood pressure, you are right. It can be classified as a secondary prevention in the normal population. Yes, it is secondary prevention.
Doctor,
yes?
smoking could be secondary prevention
the patient have asthma or?
Yes, if the patient have asthma, if the patient have coronary heart disease, if the patient have, lung cancer disease, a disease that we know that smoking can aggravate the situation, it can also be classified as a tertiary.
So all of them could be secondary?
Yes. Thank you very much. I just wanted to mention after the seventh item that please do not try to classify each intervention strictly to a level of prevention, because in some cases it may be very difficult to classify them. I will give you another example. Thank you for your comment. Please stay a few minutes. A few minutes later we will return to your question or your comment. What about intestinal cancer surgery? Intestinal cancer surgery in people with confirmed case of cancer is tertiary. But in some cases, we may offer this surgery to people without any signs and symptoms that we discovered them. How can we discover colon cancer?
By early detection.
By early detection, by colonoscopic examination. So if we diagnose some colon cancer by yearly colonoscopic examination or by yearly occult blood. What's occult blood? Have you ever heard of? Occult blood in the stool means that we ask people to give some small amount of their stool and see under the microscope and look for some red blood cells. The presence of red blood cells may be an early detection for colon cancer. If we detect colon cancer by means of screening test, then intestinal surgery can be classified as a secondary prevention. But if the patient has, overt bleeding, weight loss, and have some pains, and refers to the clinic, and after referring due to signs and symptoms, we discover that she or he has intestinal cancer, it should be tertiary prevention. Okay? So the distinction between secondary and tertiary in some cases may not be simple. There is a term in tuberculosis treatment. Who knows what DOTS does mean? DOTS is an abbreviation for treatment of tuberculosis. D is stands directly. Directly observed, treatment, and short course. Thank you. We offer, the physicians offer this type of treatment to people with advanced tuberculosis. In advanced tuberculosis, patients may cough, and by coughing, spreads a large amount of bacteria in the environment. And we try to observe them. Observe treatment means that some medical personnel, some healthcare providers will go to the home of the patient and ask them, please come here, take these medications, and with a glass of water, please take this, and after observing that the medication is taken, the person will go. It means that I want to be sure that you take the medication. What kind of treatment, what kind of prevention is that? Primary, secondary, or tertiary?
Tertiary.
Tertiary. Usually, we are thinking of tertiary because we know that the patient is in advanced stage. But actually, it is not a tertiary prevention.
Secondary?
No, it's primary. Why it is primary prevention? Because by treating these patients, I am not concerned of this patient. My concern is for the total population. I know that this group of patients may cough and may spread a large amount of bacteria in the environment. By treating this group of patients, I protect other people. So my goal is not treating this patient, although this patient is also, the second goal of my treatment. Although this patient may also have benefit of getting treatment, but the goal of Minister of Health for providing such expensive treatment is not just treating this patient. The Minister of Health may prescribe some medications and ask the patient, please go to the pharmacy, take the medication and use it. By directly observing, I want to be sure that this group of patients that are a source for infection of other healthy groups of population are removed, and the prevention can be regarded as both tertiary for this patient and primary for the whole population. Because I want to exclude the risk factor. What is the risk factor what is the most important risk factor of getting tuberculosis?
Patient with tuberculosis.
Patient with tuberculosis. Exposure with patient tuberculosis. But which patients? Advanced patients, because we know that advanced patients may spread much more bacteria than early stage or medium stage tuberculosis. So in some cases, it may be sometimes difficult to classify between primary, tertiary, and secondary. Don't worry, because it is natural, because some interventions actually have both primary and tertiary nature. Some medications can be classified as both secondary, without any signs and symptoms, and tertiary after presence of signs and symptoms. So we use this classification for simplicity. We do not use this classification for bargaining each other. We do not use this classification for as a fixed idea. Fixed idea is not suitable. Fixed idea is that I'm right and you're right, and we can have some clash for this kind of idea. Please be flexible. Flexibility is very important not only in medical education, but also in living in the population. In the society, we should be flexible. And I recommend you to be very open-minded. The fixed idea is not good at all. We have also another classification. There are two approaches for prevention of diseases in the population. In the first approach, the whole population is targeted. When the whole population is targeted, we have to use measures that are inexpensive, measures that are accessible in the whole population, and usually this strategy needs more money, more logistics. But in second approach, we may limit our effort to people who are at higher risk. For example, we know that some people may have familial hypercholesterolemia. So this group of people have a much higher risk of getting cardiovascular disease. Or some group of people may have higher risk of lung cancer. Which group of the population?
The smokers.
After smoking.
The workers that work with carcinogenic.
There is one more important factor.
Genetically, they are susceptible.
but it is difficult for me to know who is genetically susceptible. There is an important agent, an important factor that is very, very, very simple to measure. Who in the population is more than others at risk of getting lung cancer? The first important one is smoking, I agree with you. But there is another most important.
People who live in air pollution areas?
People with
Who live in air pollution areas?
air pollution areas is important, but there is a more important factor. Smoker relatives also are at exposure as a second cause. Industrial areas have a higher risk, but not so much higher. The factor that I'm thinking of, radiation is also important, but a very small group of population are exposed to radiation.
Family history?
Family history is also important, but there is more important factor.
There's nothing left.
There is a very, very important risk factor for all causes of cancer. Actually, all causes of cancer are more prevalent in a group of people in the population. It's not very difficult. Isn't there any other explanation? What is it? Third method. All people. We can select people who are older than 60 years. The risk of lung cancer, the risk of stomach cancer, the risk of colon cancer, the risk of breast cancer, the risk of actually many cancers in older people is much higher than younger people. So instead of offering mammography to the whole population of women, we can just offer mammography to women who are older than 50 years. The number of women is much less in this group, and the risk of cancer is much higher in this group. So by selecting a group who have a much higher risk of getting disease, we can use our resources in a more efficient way. So if you select all people who are smoke, we have selected almost the most important or the most risky group at the highest risk of getting disease. In some cases, in some cancers, the gender is also important. For example, for prostate cancer,
Men.
we do not do anything in women. And for breast cancer, although male also can get breast cancer, but for male, it's very rare. So it is not efficient to offer mammography to men. Okay, so some factors are very cheap, very simple. It does not need any sophisticated equipment. It does not need any laboratory examination. Just a question: how old are we?
19.
Until it's impossible to know the age of women in some cases, because women pretend to be younger than 20 years. All women in my country, all women are younger than 25 years. What is the situation in Iraq?
What was the question?
The question is that in my country, and in many countries, women do not want to show that they are older than 30 years. They are older than 25 years. It's the cultural problem. The cultural problem is that women usually like to pretend that they are young. And I'm sure that they are young. But for some reason, please tell the truth. For the sake of health, please tell the truth. If I ask you, how old are you? Please tell the truth. Now you are all, younger than 25 years. But 60 years ago, 60 years later, please tell the truth when a physician asks you about your age.
سكتها بتاع الذكر
Okay, just for joking. If we use an alternative approach that is high risk group and offer them prevention, we can then offer some more expensive measures, the measures that need some more sophisticated technologies, the measures that need more expertise, because we are dealing with much smaller groups and providing logistics, providing manpower, providing money for a small group is more affordable than the whole population. For the whole population, we have to use simpler and cheaper and more acceptable tests. Okay, let's have a brief rest. Now it's 9:20.